Welcome to The Explainer. Today, we are diving deep into the high-stakes world of abdominopelvic and genitourinary trauma, all through the lens of advanced trauma life support, or ATLS. Now, if you're gearing up for your finals, especially in fields like anesthesia or emergency medicine, stick around, because these are the critical principles you absolutely have to know.
So here's our game plan. We're going to start with a pretty incredible story of why ATLS even exists. Then, we'll walk through the initial assessment framework that's basically the universal language of trauma care. From there, we'll get into the nitty-gritty of diagnosing those tough abdominal, pelvic, and genital urinary injuries. And we'll wrap it all up with the absolute must-know takeaways for exam day.
All right, so let's start at the very beginning. Before we get into memorizing algorithms and protocols, it's so important to understand why this system was created. Its origin story really gives it all its meaning and its urgency.
This quote right here, this says it all. It captures this massive philosophical shift. Instead of blaming doctors when things went wrong, the focus became training them so things would go right. It sounds simple, but this idea was the spark for a global revolution in how we handle trauma.
So picture this, 1976. An orthopedic surgeon, Dr. James Steiner, is flying a small plane, and it crashes in a rural field. He and his kids are badly hurt. But when they get to a local hospital, the care is just chaotic. There was no system. And that personal tragedy became his mission. He realized this wasn't just one hospital's problem, it was a systemic failure. And that experience is what directly drove him to create the very first ATLS course, a system to bring order to chaos and save lives when every single second counts.
Okay, so from that tragedy, this incredible system was born. Let's get into the core of it, the structured, repeatable process that's now spoken in trauma bays all over the world. This image really shows the workflow perfectly. And the key thing to get here is that this is not a one-and-done checklist. It's a continuous loop. You do your primary survey, you intervene, you add your adjuncts, and then what do? You reevaluate. You're constantly circling back, making sure your interventions are working. It's a dynamic process for a dynamic situation.
And at the heart of this entire process is the XABCDE algorithm. Now pay close attention to that little X at the front. That's a huge deal. It stands for exsanguinating hemorrhage. It means before you do anything else, you stop the massive bleeding. Stop the bleed. Only then do you move systematically through airway, breathing, circulation, disability, and exposure. It forces you to fix the most life-threatening problem first.
You really have to burn these three principles into your brain. They are the absolute bedrock of the ATLS philosophy. 1. Treat what will kill the patient first. 2. You don't need a perfect diagnosis to start life-saving treatment. And 3. A detailed history can wait. This way of thinking gives you the permission and the structure to act decisively, even when you don't have all the answers.
All right, now for the tricky part. Let's use this framework to go on a hunt for those injuries that are often hidden but are incredibly deadly, abdominopelvic injuries. This is where a patient can bleed to death internally without a single drop of blood on the floor.
When you're doing your survey, particularly C for circulation and E for exposure, your hands and your eyes are your best friends. You're looking for these clues. Any bruising down in the perineal area, a leg that's weirdly rotated or seems shorter than the other, these are massive red flags for a major pelvic fracture, which means you have to assume there's major hemorrhage.
Say our patient is unstable, their blood pressure's dropping. You need to find the bleeding like now. You've got two main tools. On the left, there's the FAST exam. That's your go-to ultrasound. It's quick, non-invasive, and it looks for free fluid, which is usually blood. On the right, the DPL. It's more invasive, but it's super sensitive. Here's the bottom line, though. For an unstable patient, if either of these is positive for blood, you stop. They go straight to the operating room. No delays.
The type of fracture can actually tell you a lot about how bad the bleeding might be. That vertical shear on the left, just incredibly unstable, rips through everything. And the one on the right, sometimes called an open book fracture, it literally springs the pelvis open, creating this huge space for blood to just pour into. Both of these are associated with life-threatening bleeding.
Okay, this slide right here, this is a huge, high-yield takeaway for your exam. You need to have this clinical triad memorized. Your patient's blood pressure is low, but you do a FAST exam and it's negative. So, where's the blood? A negative FAST does not mean there's no bleeding. If you see a pelvic fracture on the X-ray, this triad is screaming at you, retroperitoneal hemorrhage. The blood is hiding behind the abdominal cavity, where the FAST exam can't see it.
Okay, let's switch gears a little and talk about the genitourinary system. This is an area where missing one small sign during that initial survey can lead to some really significant long-term problems for your patient. If you see any of these signs on your exam, alarm bells need to be going off in your head. You have to suspect a urethral injury until you've proven it's not there. Blood at the tip of the penis is the classic sign, of course, but also keep an eye out for that perineal bruising. Oh, and while everyone learns about the high-riding prostate, it turns out it's not actually that reliable, so don't stake your entire diagnosis on it.
And this brings us to a huge, non-negotiable safety point. This is critical for exams and even more critical for real life. If you have even a hint of a urethral injury, you stop. Do not, I repeat, do not attempt to pass a Foley catheter. You could take a partial tear and turn it into a complete transection, a much, much worse injury.
So what's the right move then? It's these 3 simple steps. 1, you suspect the injury based on your exam. 2, you hold off on placing that catheter. And 3, you get a special X-ray called a retrograde urethrogram, or RUG, to make sure the urethra is intact before anything gets inserted.
All right, so we found the problems. Now what do we do about them? What are the immediate life-saving interventions we need to be doing right there in the trauma bay?
For that unstable patient with that open book pelvic fracture we talked about, your first move is to slam that book shut. You apply a pelvic binder, or honestly, even just a bedsheet wrapped really tightly, right over the greater trochanters. This simple move reduces the volume of the pelvis, puts pressure on the bleeding sites, and can literally be the bridge that gets your patient to definitive care alive.
Now, some things are just non-negotiable. If you see any of these hard signs, especially in penetrating trauma, there's no debate. The patient is going directly to the operating room. We're not stopping for more scans, instability, guts hanging out, peritonitis. These are all one-way tickets to surgery.
This image is a great reminder of a classic trauma rule. Do not pull out an impaled object. I know it seems counterintuitive, but that knife or piece of rebar might be the only thing plugging a hole in a major artery or vein. If you pull it out in the ER, you could cause a catastrophic bleed. It stays put until the surgeons have everything under control in the OR.
Okay, we have covered a ton of ground. So let's boil it all down to the key, high-yield learning points. These are the things you absolutely have to lock in for your exam and for your clinical practice.
All right, let's run through these. First, hemorrhage is what kills people with pelvic fractures, and it's the thing we can fix. Next, don't go rocking an unstable pelvis. You'll just make the bleeding worse. Remember this one, a negative FAST means nothing for the retroperitoneum. Also, a normal chest X-ray doesn't mean the aorta is okay. And a huge one, CT scanners are a luxury for stable patients only. And finally, say it with me, suspect a urethral injury? No catheter until you get a RUG.
And that's a wrap on our explainer on the ATLS approach to this complex trauma. So I'll leave you with this final question to think about. If you can answer it confidently, you have absolutely nailed a core concept from today. Thanks for joining me.